So this case, so 3 implants placed and removed here, right?
Yes.
So we are planning for a reimplant here. How many months has passed by?
6 months.
6 months. But still the bone healing is not very much satisfactory, right? So patient is taking vitamin D, right?
Yes.
So we'll plan here. So 3 implants, we will see at the same time what is the healing happened in that old implant removed side. Okay. So not only that, this patient is having infected canine here, the deciduous canine. We are not going to touch that. So second premolar and 1 molar, right?
Yes.
So we are planning for 3 implants. So this most probably will be 7, right? It's actually 2 teeth missing, but we are going to place 3 implants. That means better to select a smaller diameter implant, otherwise the inter-implant distance will get compromised. So first we will plan the mesial implant. That is the second premolar site. Okay. You can see this may be the old implant defect, right?
Mm.
So we have to approach palatally, and we can go till the nasal floor. Okay. So the length is almost 12 mm. Okay. So what I am doing is slightly tilting it mesially. Okay. To see if you see, if you tilt mesially, you can see the impacted
Root.
canine root. So we have to place the implant along close to the canine root. That is more good actually. There is no problem with it. Okay. If you see, the density here is around 628, 600 something like that. But if you go close to the canine root, the density is 1300 because of it is cementum, right? So there is nothing wrong in placing in the cementum also. Okay. We will get good stability. So the mesial implant will be foolproof. Okay. So you can place even a basal also is a good choice because the bone quality is good. If you are placing BCS design, then you have to include the gum also in the length. So it is almost 14, 3.6, 14 we can place, or if you are placing compressive, you have to place a 12 mm implant. Okay. So we will see the 360-degree view. Okay. So this is the defect. Okay. This is the defect. So better to, so this much amount of rough surface will be exposed. So better to place a basal design. Okay. Now we will convert into 3.6. Okay. Now we are planning the distal implant. Okay. If you see here, this is the old implant removed site. Most probably this is the palatal root of 6. Okay. So this is the palatal root socket. We could have placed some wider implant, basal 5 something. Okay. So either we can place implant in the same site. You can go beyond the socket depth, we can reach till the nasal, the nasal floor. This is nasal floor, this is sinus floor. So if you go in this direction, it is sinus nasal floor. If you go in this direction, it is sinus floor. See, the bone density is around 800 some. That is good. You can place a 3.6 longer length. If you include the gingival length, it is around 617. This is one option. Okay. Placing a 5.5 is not a ideal option in this scenario, because if you place 5.5, it won't go beyond this end, right? It will expand this thin palatal plate and it may break also. Okay. So placing 5.5, it's not advisable here. We can place a 3.6, but going till the nasal floor. This is one option. Okay. Now we'll see the 360 degree. Okay. Okay, it looks good only. But that is one more option is also there. This is 7, right? The molar is 7. So this molar is 7. Just behind the palatal root and just in front of the 7 root, you will have good bone. You will see that. Okay, can you see? You have to tilt distally. If you see, the bone is very good. Buccolingually very wide. Height also it is around 11 mm. The only thing you have to tilt it distally. Okay. If you tilt mesially also it will. If you tilt more mesially, you will be reaching the palatal root defect. Okay, so exactly between the palatal socket and the root of 7, you can place. A compressive will do, right? 4.2 into 11.5 or 10, whatever it is. Okay, because the width is good. Why can't we use a wider diameter? Okay. So how to exactly find this spot? There are two techniques. What you can do is just poke your drill and find the palatal socket first, right? Okay, this palatal socket first. Then using it as a guide line, just drill distal to that palatal defect, palatal socket defect. Okay, this is one option. Our best option is put incision open flap, and you can see the palatal socket clearly, and the bone between the palatal socket and the 7 you can see clearly, and you can drill. For this case, it is better to open the flap, or you can do the dynamic navigation. If you don't want to open the flap, you can do dynamic navigation. It's the ideal case for dynamic navigation. Okay. So this is a close spot, right? So that is why it is showing in red, showing that it is close to the other implants. This is the middle implant, right? Did you place 2 implants or 3 implants? 3. Sure?
Yes.
Because I couldn't able to find the middle implant defect. Maybe it healed good. You can place a thin implant, right? 3.5 into 11.5 or 12. You can place all close to the nasal floor, right? So mesial is 3.6 into 14. Okay, middle is 3.5 into 12 or something. The distal implant is 4.2 into 10 or whatever it is. The thing why it shows the implants close to each other, it shows in red, because of the design of the implant in this software is almost parallel. But what implant we are going to use is a very tapered one. Okay. See, what implant design we are going to use is, it will taper very much near the apex. So even though it is showing in red, it is not a problem. Or what we can do is we can place a basal implant in the molar area. Okay, 3.6 into 14. Okay, the bioline basal has got lot of threads. Now the thread length is more with bioline, so you can use a bioline basal. You will get good stability all along the alveolar bone. If you use a symplant basal, the number of threads in symplant BCS is very less. It will catch only the apical part, but if you use a bioline basal, it will catch the alveolar part also. In the way you can reduce the inter-implant distance issue. So 2 BCS, middle one only compressive. Okay, that also you can place. Or you can choose a 3.5 mm compressive implant here. All options are there. So this is axial. Now we'll see the right side. I'm not going to do anything for the right side. The canine, here we removed the impacted canine, right?
Yes.
Both the deciduous and the impacted canine. The bone defect is still there. This is called delayed healing. Okay, delayed socket healing. Theoretically, this happens. For some patient, the socket doesn't get filled with bone. Okay, it is called delayed wound healing, delayed extraction socket healing. What you can do is you can give Elia and you can curate the socket and you can induce bleeding and you can wait for another 2 months. This is one option. Anyhow, we will plan an implant here. It's a huge defect, right, after removing a canine. If you see here, there is no bone. Only thin buccal plate and palatal plate and 3 mm of see, even after 6 months the bone healing is not good, right? Even after, if you wait for another 3 months, it will be the same, I guess. We have to check whether the patient is taking vitamin D and all properly. If necessary, we can take more test. You can place a BCS, but the risk is more because you are getting stability only from this part. Of course, the nasal floor is very good, 1500 units HU. That's or another option you can do is you can place the implant and you can do delayed loading. Yes, that also you can do. The patient is poking the implant with tongue, then that also will get mobile. Or you can, what we planned is to give the Maryland bridge now, right?
Yes.
That is a very good option in this scenario. The scenario is looking very ideal for Maryland bridge. You can give a Maryland bridge. Definitely it will come for a long time if you design it properly and if you bond it properly, and if the material is a composite related material. Okay. If you do HIPC, in HIPC it will bond nicely. It will come for long. In the meantime, the bone also will get healed. Even if you place the implant, you can give a Maryland type of bridge and bond with the adjacent tooth. It will help for integration. So these are all some challenging situations. You can see the bone defect here. The canine most probably would have been here, right? See, it shows in red because this distance is greater. However, this is a basal 3.6, but the shank here, shank will come. It will be around 2.8, right? It won't be 3.6. if you put this as a BCS, here the shank diameter will be 2.8. So inter-implant distance is not a major problem if you use a basal design or a small diameter implant.